Okay, so welcome everybody to the Family Medicine Grand Rounds for today, June 21st. Your activity code is listed there for those of you who will be claiming CME credit for this presentation. Please make sure that you do that before midnight tonight. And if we can go to the next slide here. If you have not yet registered, you'll need to first contact the CME office. And once you have an account with them, you can then text your email address to the number listed there. And then from that point forward, you can text the activity code. You'll send attend plus the activity code to the toll-free number. But if you have any questions or concerns, please reach out to us. Next slide. And so if you are claiming credits, please, again, make sure you do before midnight tonight, but also be sure to check your transcript every so often. And you can do that by going to the CME office website listed there. And then just click on transcripts and log in, and you should be able to see those. If you're having any issues, please reach out to us. Next slide. And of course, don't forget, if you are an AAFP member, you can also claim credits to their system for this presentation as well. Their information is listed if you have any questions. Next slide. We do want to make sure that we reach these nationally established physician core competencies during our family medicine grand round. So you can see those listed here. Next slide. And Dr. Gonzalez Schlenker has no financial relationships with ineligible companies to disclose. And I do want to mention questions are encouraged. We're going to go ahead and have y'all put those in the chat box for this presentation, and those will be addressed at the end. But I will let her go ahead and begin with her presentation. It's the social determination of health and our striving for solidarity. So I will let her go ahead and get started. Oh, you're muted still. Let me send you. There we go. We can hear you now.
Okay, great. All right, let me just get this here. Okay. So let me just get this down. Well, good afternoon, everyone. And my objectives today are to describe the harm of poverty on health and the implication of healthcare as witness of that harm, to define social health using the interaction as a unit of analysis, and to facilitate dialogue and collaboration to respond to the local need to build community. Those are like my big objectives. And so we begin with, what is healthcare? In social medicine, healthcare is defined as the organized collective response to the process of health, disease, care. And why do we institutionalize care? Because we as living beings are vulnerable. And that is how I like to frame our talk today, from a lens of vulnerability, what Martha Feynman calls reasoning from the body. In our life course, as we move from birth to death, we have two stages of high vulnerability, one of immaturity and one of decline. For us to have a full human life, during those stages, our bodies and minds depend on co-regulation by the body and mind of a caring person. And we have wired in ourselves a level of sensitivity to respond to those stages of vulnerability we call tenderness. Both babies and elders trigger the tenderness response in us, a delicate, heartfelt attentiveness towards the vulnerable that gives us information about how to best relate to them as change in their participation and their autonomy unfold. Each child matures in a unique way. Each elder declines in a unique way. Tenderness let us know how life is changing. It is that heart connection that makes us mutually human. And our species has solved this by overlapping 4 generations so that at any given time, there is a core of caring where these vulnerable stages can receive the necessary attention. The more tenderness exists at the core, the more effective the care acts are, the more efficient our use of energy. But vulnerability is always there because at any given moment during our working years, we can get really sick and die or have accidents. Weird things can happen to us unexpectedly that make us depend on others in times when we were expected to be caretakers. Households are vulnerable in that way. They need each other. They intermarry, extended families and friends create networks of care. We evolve in tribes, groups of interdependent people sharing a language and an ecological niche that sustain them, creating cultures. But beyond our support network, we have the capacity for solidarity. Once we recognize the other as a human, a floor of shared humanity is created below which the person should not be allowed to fall. Think of the story of the Good Samaritan. Think how a tragedy in a movie makes us cry. We can be moved by the suffering of strangers, by their vulnerability. When we care, we give our metabolic energy to a different body. But we have limited units of energy. So we build shared humanity from the inside out. Our core has first claim in our energy, then our extended network. And if our caring has been efficient, we might have enough left to give beyond that. Healthcare as an institution healthcare is the institution in our society that best represents our capacity for solidarity. As a patient, we go to healthcare in a stage of high vulnerability. We are confused, fearful, in pain, and we trust that we will be cared for. I believe all of us working in this field are here because we want to respond to that trust, because our hearts are moved by the suffering of strangers. But solidarity's floor of shared humanity is a work in progress. It remains an ideal in our hearts, in our moral codes, and many believe we lost our way. We are seeing a growing number of people living in inhuman conditions. For many of us, the assumptions that the world is benevolent, that life is predictable, and that the self is worthy are being shattered, leaving us disoriented, distrustful, and traumatized. Good healthcare, with science as its amazing consensus tool, help us understand what is going on with us humans. Can damage to our sensitivities teach us about their existence? Can we learn from the counterfactuals, what could have happened but didn't, of our patients' stories of brokenness? That is what I'm hoping to humbly and briefly share with you today. My experience after listening to thousands of stories our promotores, community health workers have brought me as their supervisor. And also from witnessing healthcare's mission of solidarity progressively lose its force to anchor the system. Promotores are not clinicians. They don't diagnose and treat diseases. They are trust builders. They are people with a great capacity for solidarity, and they try to connect with the most vulnerable in our city. They practice what we call the ethics of the heart. The reason our program was brought in by our department almost 12 years ago is because we realized we needed to get closer to the world of our patients to properly care for them, because we were missing information. Promotores act as bridges of trust so information can flow between patients in households and clinicians in practice. The standard promotores use in their work is one of positive health. Our species' normal functioning as vulnerable beings that are cared for and care. Instead of focusing on pathogenesis, our focus is salutogenesis, the generation of health. and we expect healthcare to be health generating for our patients. That is the promise the institution makes to people. That is what we are accountable for. From salutogenesis theory, we learn that as they travel their life course, healthy people constantly update their sense of coherence and are able to experience life as comprehensible, manageable, and meaningful. And for each time the sense of coherence is updated or not, a story can be told. The organic time of our lives comes packaged in stories. A healthy life is a trajectory of both flourishing and fruitfulness, aiming at dying well, old, loved, wise, and in peace. Mission complete. So as patients receive care, the promotores ask, is this comprehensible to our patient? Is this manageable? And is it meaningful? That is it affirming enough that it engages their internal motivation to continue on and cherish their trajectory? We call this self-care generativity. And lately, the answer more often is no. Healthcare has become more incomprehensible and more unmanageable. So instead of updating our sense of coherence, it undermines it. It makes us less healthy. And our task is to close those gaps so the interaction becomes a story of care. That is how our promotores have been able to build trust. They use tenderness. They empathetically listen to understand the patient's vulnerability. That information tells them what actions to take, and they take them. And lastly, they confirm if the actions worked, if the update happened. Notice how caring is nonlinear. It is a loop in which we deploy our energy and we expect it to produce results. It is a story with a beginning, a middle, and an end. For us, a story of care can originate in any of the two poles, the caring one or the cared for one. Because we are clinic-based, many originate with you, the clinicians. Often, it is one of those new ICD codes with a social determinant, or something comes up that you lack information on. For example, and you, doctor, if you're there, you'll know what this is. Based on claims, you get a bad rating by your patient's insurance because he has diabetes and has not gotten an A1C in 2 years. You look it up and realize that you ordered the labs. But this is a young adult that is now more than 6 feet tall with severe autism that does not allow anyone to draw blood from him. So you contact me and I assign this patient to a promotor under one of our pathways of care. There's several of them, and this would be a task specific. We need an A1C. The promoter goes to the household and finds that it is a very poor one, that care for this patient has been absent and fragmented, that he did not get special ed to develop social skills, that the agencies that could help him have a waiting list of 7 years for people that cannot pay. Then our PharmD suggests that we could use the at-home A1C test when he comes to his next appointment. From our clinic share fund, promoter buys the kit. But when the day comes for the appointment, the patient doesn't want to get out of the car. So we then decide to bring one of the residents and do the test at home. And we decide mom should be the best one to do it. But patient becomes suspicious, and when mom approaches, he gets angry. So we leave the test with mom. She says she will find a way to do the small prick. Promoter suggests to do it when mom is cutting his toenails. We've done a lot of things, but none has worked yet. So we keep the story open. You are a wonderful doctor, and your rating of this patient care is wrong. The story can also originate in the household poll and needs to travel to the clinician to get completed. For example, one of our patients has been operating an iron press at a dry cleaners for many years. This is a job done standing all work hours. Patient diabetic neuropathy has progressed and his job is becoming intolerable. You prescribe new meds. One day, the promotora gets a call from the patient's wife saying that his boss has asked him to stay overtime due to high demand during the holidays. The patient does not want to say no because he's afraid of losing his job, and the household is barely making it. Promotora meets with them at home, listens to and acknowledges the patient's fear. They brainstorm. They come up with a plan to ask you to write a letter to his boss saying patient should should not stay in his feet for very long. I tell you the story and you willingly write us the letter. But the patient is still afraid. Then wife asks to a young cousin that is looking for a job, and they add the person to the plan that that with the letter, they will bring the cousin and he will operate the iron for the extra hours of the holiday season. They rehearse the encounter with the boss, with the promotora, and ask for a meeting. They bring your letter and the cousin, and the plan works. But notice how both stories are not getting to the root cause. That even though promotores can sometimes, by being there at the right time and the right place, can even save lives with their work, it is not for the long run. That what we are dealing with here is poverty, and a metric that is decoupled from the care you give. And both trends are growing. Trust is getting very thin, and it needs to be rescued. The healthcare setting itself can neither solve the health challenges faced by our patients, nor ignore them. And I will add, this moral dilemma is not good for you. We are slowly realizing that we need to look upstream, as this report from the National Academies of Science, Engineering, and Medicine advises us. This is one of the metaphors. You might have heard of the river metaphor, in which two people see a person drowning and rush to the rescue. They are very glad they could do that, and the person is thankful. Then they see another one, and they do the same. And then they another one, and they see more and more drowning people needing rescued. But by now, they are exhausted. So they decide to go upstream to find out who was throwing people in the river. They realize that if they don't stop the upstream problem, they cannot solve the problem of drowning people. This metaphor points at the social, political, and economic structure that causes discrimination and exclusion and is baked into our culture, like racism, sexism, ableism. Solutions like cultural humility, as well as listening to patient stories, are promoted. There are great efforts to integrate this structural competency in curricula for medical students and residents. And I think it's very good that we should realize that we are all implicated in maintaining these unjust structures. But what do we do with that implication? Feel guilty? And what do we do with that guilt? I think that besides looking at the big picture, we should also look at the deep assumptions inside us that weaken our capacity for solidarity. Let's take redlining, for example. Why does the map of San Antonio's redlining, a racist federal banking policy in the 1930s, matches the map of today's diabetic amputation? Dr. Christine Drennan gave a talk on this, implying a causal relationship between the two. We know the racist policy has changed. It is illegal to discriminate based on race when we ask for a loan. But if we go deeper, we find that we have cognitive frames that allow us to diffuse or displace our responsibility and morally disengage when we witness the inhumanity of poverty. We tell ourselves, I didn't cause this. But now we're being told that no one is off the hook. But not how we got hooked. We wouldn't even know how we got here. But if we go deeper, we can find the generator function of our social design. A win-lose game. Game theory. The distrust assumptions of economic theory and its abstract metric of money as a measure of value. A value that we believe is amoral, as if we were just collecting points in a game. Money is just numbers replicating themselves, we are told. And we believe that if the economy grows, human well-being grows. But this has not turned out, and we now know better. Money as a metric is insensitive to what is good for us. It can grow from people being sick, from wars, from human trafficking, from preying on people's vulnerability. In our work with the poor, we realize that unless our moral imagination is able to contain that value metric and produce a different source of order, we will never solve the complex problems we have, because money, when it's displaced, disorders life. We see it in the manner in which we see it in healthcare. Accountability for healthcare should be organized by first getting the information from caring, then applying science to that information, and lastly, by financing the application of that science. But that sequence cannot hold the system in place. The accounting metric, time 3, moves faster and leaves time 2 and especially time 1 behind. But especially, we see how this metric is insensitive to our progressive loss of meaning. Thousands of stories the promotores bring to me have this pattern. Poor people can cope just so far, but when the injustice is obvious to them and they are left unheard, they suffer a double abandonment that disrupt their capacity to care. It is in these survival states that Claudia Card calls gray zones, where victims victimize each other. Course of caring break. Deep wounds and trauma happen that medicine cannot cure. And we become witness of their dying young. But being a witness is different than just being a bystander. Witnessing knows the story and engages our morality. Donna Berwick, someone that knows our healthcare system well, makes a call to our morality. It says, when the fabric of community upon which health depends on is torn, healers are called to mend it. The moral law within us insists so. But he doesn't give us a full explanation of what that law is. We proposed that the first step is to accept that we cannot play games with life as if we were outside of it, making the rules and controlling it, but instead that we accept that life contains us, that we are all vulnerable, but that is also where life is beautiful, and that we need to connect the scientific dots of what caring and being cared for do to us, to discover what is that shared humanity that we hold as our ideal. We know so much more now than before. And I think the vulnerability that money has created can help us transition to a planetary culture. So we propose that we shift the question of our accountability from a discourse of guilt to a more positive terrain of historical responsibility. That we should work together to make solidarity a gradual reality. There are many arrows already pointing in that direction, but we need to explore this more. We must accept that the homeless person in an examining room is as human as we are, and find a way in which they can feel our caring. Because when our cores have been broken, we will need to build shared humanity from the outside in. When our promotores go into households, they find amazing stories of resilience and resistance that still recognize authentic caring. But some no longer do, and we have to walk out. But we carry the lesson of that story as a proof of what breaks us. We define social health as the capacity to build community to trust, and we make the interaction its unit of analysis. An interaction, its own organic order, as we co-create a story of care. We must accept that our linear metric is too simplistic to contain us, that an amount of money cannot contain a story of care, but a story of care can contain agreements about money, that a market cannot contain a community, but a community can have a beautiful market. Promotores go into wounded households and explore possibilities for salutogenic interactions, what we call braiding, in which persons find a way to coordinate their intentions and their actions and make sense together. They help people build a unit of trust by answering together these 4 questions. What do we want? Why do we want it? What do we do? And what do we get? This formula, our nosotros formula, is like a catalyst that can be applied to any interaction and make it orderly. But promotores will not fix our patients' poverty or their premature mortality. We need healthcare to back them up. In our nosotros approach at RBG, we are keenly aware of the tension we are dealing with between the mighty force of accounting and our efforts of accountability so that trust between our clinicians and our patients survives. But we won't be able to do it alone. How can you, with your own burden of administration, be part of this? You won't be able to braid new core for your patients. That will be the work of the people themselves. But you can facilitate what it happens. You can facilitate that it happens with what the social care report calls the 5 A's of social care. The first one is to be aware. Be aware of what we're dealing here with. Be aware that food insecurity, lack of transportation, lack of housing are all symptoms of the deep engine in our social design, and that we are very good at generalizing the win-lose game. So change begins with us. Then start or respond to stories of care using any of the other A's. Be curious. At the individual level, you can adjust your care to the reality of the patient. Make sure, for example, that a well-informed someone is at home when they need to be discharged. You can also assist with something tangible in the here and now, like our HEB cards if they share that they don't have food at home. Prepare your practice to be able to do that and work closely with your social workers and your community health workers if you have them. These individual A's are short-term, but sometimes they make things possible. Remember, small is not the trivial. The money in our share fund is carefully allocated to make sure it is embedded in a story of care. But at the community level, you can bear witness and align your work with others that share our goals. Ask new research questions together. Collect data that can allow us to advocate for structural changes that can benefit many. We can begin with the data collected by the Health Collaborative. Every 3 years, the Health Collaborative, a volunteer group of health leaders in San Antonio, commissions a comprehensive community health needs assessment for Bexar County. The 2002 report has over 100 indicators visualized by almost 200 charts and maps describing geographic and demographic health-related trends on health disparities. We have community environment, that access to care, preventive care, well-being, illness and injury, and death statistics. And it is no coincidence that the zip code with the highest level of poverty, 78207, where our clinic stands, has the highest rate of child abuse and neglect. To me, this is life shouting at us, I can't make it here. I can make it this way. Bear witness, don't abandon me. And what if we were to listen? What if we grab those helicopter view bad statistics, go into that zip code and talk to the people there and tell them that we care? Many years ago, I did that in an immigrant community in Racine, Wisconsin. It was called Saber para la Gente, knowledge for the people. The first Wisconsin Minority Health Report had been published, and when I look at the stats, I found them so limited to guide action. So I got funding for this research question. How do people leave health indicators? And following Paulo Freire's dictum that when the poor describe the reality using concepts created by those that do not share it, they live in a culture of silence. And using Augusto Boal's Forum Theater, I listened to their stories. I presented them back to them and made them as spectators of that stories and asked them, how would you change this? We have 4 plays, one for each group, adolescents, women, men, and seniors. The results of that study showed me the potential that exists in people to name and change the reality when spaces for mutual vulnerability are built. And that's what trust is, an optimistic engage in a vulnerable situation. We think that in these times of polarization and distrust, we can recognize each other as vulnerable humans that need and can build trust, one story of care at a time, and start weaving a new social fabric of solidarity. Thank you. I'll take questions if you have.
There are a couple, I don't know if you can see the chat box or if you need me to read them out, but there are a couple of questions here in the chat box.
Mm-hmm.
The first question says, delving into social determinants of health during a 20-foot medical visit in a busy ambulatory care center is a challenge. The ability to hone in on key social determinant factors during this short period of time is important. How can EHR tools and the care team help to screen for the critical social determinants of health factors that are impacting the patient's health currently and long-term?
Yeah. And that is one of the conundrums that we have, right? So they're you know how constrained you are just to even get to see the whole patient's body, right? And then you're gonna open this potentially endless conversation about the social determinants. And it's impossible. First of all, you don't screen for things you don't have answers for, right? You don't screen for things that you cannot solve. The same thing goes with the ACEs question, the adverse childhood experiences question. The setting of the workflows that we have do not allow that. So how do we are aware that those social determinants are there and take them into account is what we're trying to do with the promotores, right? So I try to make sure that I distill, knowing you and the demands that you're facing, I try to distill what I know you should know about this patient. But most of the things I don't even let you know because I know what you're gonna focus is to focus on the doctor's role. However, we struggle. And that's why I wanted to have this presentation when Dr. Shi brought the idea to me, because it's becoming harder. The patients that we're getting are facing more and more inhuman conditions that are overwhelming and for which your work can have such little impact. How do we deal with this? Where do we go with this conundrum? Like that statement says, healthcare is not going to be able to solve this. So do we bear witness to who and who wants to listen to our witnessing? And that's why, as I ponder and break my head on continuing our promotores program, I think it's one story of care at a time. It is just not letting go of that engagement with a human being you have in front of you and making sure that when we're deploying our energy, we're gonna do something that is possible, that can give us results. And we do this together, right? So a lot of the things that I know the patient could do or could have are not going to give us results. So I don't even bring them into your radar. But what I think that your deployment of energy will give you result, then I'll let you know. I even feel concerned when out of nowhere, I put in your chat, in the chat, a request from a patient that is not in your panel today. That's going to add another 10, 15 minutes of you going into Epic, looking at that chart and figuring out what's going on while you have patients waiting, right? And that's why I worry, not just about our patients, I worry about you. And the level of demand that can make it so much difficult for the patient to feel cared, the level that they need to feel cared. It's like both extremes are becoming harder. So we are brainstorming one story of care at a time, reaching out to other agencies that actually are facing the similar thing. You have education feeling the same thing. And I know that if we already have our new residents there, they heard this talk yesterday when we talked to the residents, GME, but Christine Drennan was there, and Dr. Scott Jones and Dr. Wunda John DeWood from the health department, and we are debating ourselves. How do we do this, right? How do we believe that those tender moral ideals that we became healthcare workers for don't get crushed, don't get shattered? And that's the question that I would like us to ponder. So I don't know. I'm stuck. I don't know. We need to become more creative. And in the meantime, don't shut our hearts. So any advice, we'll take it. I know that we're losing some examining rooms. How's that gonna make it easier, right? So any advice from you?
Carolina, this is Byron Hepburn. Can you hear me?
Yes.
Yeah, excellent presentation. I would think a good start would be to help facilitate the ease of accessing the helping functions like Via Trans, the food bank, senior centers. So our busy faculty and residents and students in their clinic click on through Epic or something to make it more expeditious, to make those supporting functions more readily. I use the example in a lot of my arthritic patients. I get them over to the aquatic center, but I have to literally, get one of the MAs to copy a sheet, and so whatever we can do to help facilitate, since we don't have a social worker present, do that supporting functionality. Develop a list of those helping agencies that will help mitigate some of this. It won't solve what we just talked about, but it'll help mitigate some of their challenges.
Yeah, and like the residents yesterday, they got several of those agencies to just to know they're there. But again, the help agencies, the social support is loaded. It's loaded. We have long waiting list. We have long waiting on the phone. Really after COVID, they're saturated beyond capacity. So, I mean, you can send them to us. If you are our FHC, send them to me. And believe me, we try, the promotores try, that's what we're doing. And we work very closely with our social workers. But it's just that the services available are not enough for the demand. And, whatever is there, we grab. But there's some that are just not there. And, waiting list for Saha, for housing used to be 2 years, 3 years when we started. Now it's 7 years. And my patient is being evicted today. Right? So, or next week. How many patients do we have that are homeless? How many we have that are sleeping in their cars, that are living in their cars? And it is that sort of like explosion of like inhuman conditions that just has me very worried and alarmed, and it's not good for anybody, and especially the young, our kids seeing that in our young profession. And that's why we go with promoters, and I will go like, we're in a transition. We have it in us to do better. And we just take one story at a time. This is how much we could do. If we're not gonna get this done, then let's don't promise, right? Don't promise the patient that we can give an HEV card every time they need one. We won't be able to. And we tell them, and then it comes back, we like, can you please give me another one? They cut my food stamps from pre-COVID to now, like 80-70%, and she still have the same 4 little kids. So what do we do? What do we say? Well, go to the pantry, go to these. I went, and they don't have transportation, or they already got what they could get, or there's no healthy food there. I mean, that is the navigation, but not just that. It's just that when the person is in that level of stress and despair, they're less, able to take the steps as if they were rational beings, that they're just, executive function untouched. No, they cannot plan well. And in their planning apparatus becomes damaged, because the future is always a target, moving target. So do you take your medications? No, but you don't have food on the table. So what's more important? And it is that situation that we're finding in our patients. Remember, we have the poorest of the poor, right? But as we walk into the households, it's the same thing. And yet, we're just healthcare, right? The broken bodies and minds are coming to us, but a lot of things have happened out there before they ended up in our doors. Can we bear witness? Can we aspire to different stories that we tell ourselves? But also, can we make justice to that tenderness, to that capacity for solidarity that is in us, that we need to give and to receive? And I don't know that we've done enough science there. I think we could do more. I don't know if that answer the question. That's a long line.
Carolina, Doc Hepburn again, for the residents, I would just offer as you move forward professionally, wherever you end up, consider being engaged at the policy level, at the county, city and state. You know, I guess it sounds like Dr. Wu spoke to you from Metro Health, but you know, we had during the pandemic, the Community Response and Equity Coalition stand up, and a number of our faculty are participating in that to help drive the broader strategic dimensions to this. Those are opportunities for you to engage, but certainly I would be aware, no matter where you are, develop your own list of what resources are available and viable, so that I hear what Dr. Schlenker is saying about capacity, but some of them do have resources, to include a lot of the churches in your urban areas do provide some degree of support. You're not going to resolve the issue, but they help mitigate some of the suffering. I know our parish does that every Saturday. So look at what resources you do have to make those positive blips on the screen. Thank you.
Yeah, I agree. I think it's there. We just need to find it and connect it. I am an optimist and I believe we have it in us. It's just we need to create the frameworks in our behaviors, in our thought processes, and don't despair, right? Our patients make us humble.
Dr. Schlenker, there's another question in the chat.
What is it?
From Dr. Obaid.
I'm sorry, I cannot see the chat.
How do the theoretical underpinnings you described with the promotores coincide or overlap with the minoritized stress model, specifically with Black and Indigenous populations? How is racial trauma incorporated in overall health?
Yeah, wait. Let me just say it again. Well, basically with, I don't know if I understand the full. Can you repeat it? Let me see. I don't know.
Maybe Dr. Obaid can.
How can, oh, okay. How do I can see it now. How do the theoretical underpinnings you describe with the promotores coincide or overlap with the minoritized stress model, especially with Black and Indigenous populations? How racial trauma incorporated? Is racial trauma incorporated in overall health? Yeah. Well, I mean, again, that's what, you know, the red lining is this internalization of devaluation. One of the things that we battle tremendously with, and that was one of my questions with Christine Drennan is, okay, so we're telling the residents that these two maps overlap, right? The amputation map and the redlining map, which was this racist theory, this racist policy, but we're not telling that to our patients. Why? If it is their health, what we hear from our patients is that it's in their genes, that diabetes is in their genes. Are we talking about epigenetics when we talk about this redlining? And decades later, almost 100 years later, this is happening. One of the things too that I emphasize is, you know, remember microaggressions, right? That is another understanding of our sensitivities. It's like, look at the counterfactual. What would the counterfactual would be? That micro affirmation and how healing micro affirmation are, not to do it artificially, but actually to develop the capacity to put them into practice, because that's our natural way. But if you never experienced those, you don't know that they even exist. So as to the minoritized stress model, I don't know that I know exactly what it is, but if you can add that to this chat, Dr. Obaid, would be great. To us, if I may add, is that as we see patients' sense of coherence being denied because they do the money, because money this, money that, and it is all this economic closing and closing into and making their life less and less able to do that loop of the sense of coherence. That's what we see. And then some bad things happen there. It's like cornering a human being. Any advice, send it my way. But I do think that we need to look at the larger picture, because the patient need more attention and you have less attention to give them. That's the bad formula. That's unsustainable. And it's not good for you, and it's not good for the patient. So we're trying to be creative.
Dr. Schlenker,
Yes.
Dr. Hyen put in the chat. He's wondering if you could share information about the share fund in the
Yes.
department.
Yes. So as you know, the share fund started in the pandemic when Dr. Prosani realized that our patients were coming in with food insecurity, and we just did this fundraising, and all of a sudden in a few days we had a little money, and we started actually buying the food, and promoters were delivering the food at the patient's door, especially our homebound patients. And from that, our share fund grew. And I know several of you had made some very generous donations from your personal families to that fund. Some of us are, constant donors. And, there's a few $1,000s there. But I met with the person from the development office, because when you are a constant donor, they come and they want probably to keep going and keep giving or give you more or give more. And I asked her, each of the donations that each of the expenses from our share fund is just so carefully tailored, because we know we don't have a lot of money, that is embedded in a story of care. And I think we should put that in our webpage. The human story that each of these very small monetary contributions make it happen. This makes this story happen. If we didn't have these $50 or these $20 or whatever, we say, okay, there's a share fund, plug it in. We couldn't do the whole story, and all those embedded in that story will fall. Like, for example, this A1C kit for this, severely autistic person, we got from the share fund. And just like that, but look at the big story that it was. And just like that, we see when money becomes when accounting becomes part of accountability, then it has its right place. It is part of our shared humanity. We can do that. There's nothing wrong with money or with markets. It's just that it cannot contain the whole picture. There's a lot more to us. Although the two stories I share with you, they don't get, into the claims to the insurance company. We bought the A1C test. So the share fund is, as you open our webpage, is right there. And then it has a webpage that you can click and you can donate. But I hope that we can do more with that little money and show how we are more than that we have things that are not purchasable, and those are the most valuable things. So I don't know if that's enough about our share fund. If you find yourself stranded with a patient and they just, many times we have paid co-pays, patient takes forever to make it to the clinic. We finally get him here. and then he doesn't have enough money for the copay. And that patient is not going to leave. We are going to pay that copay, right? So one of the promoters gets it out of a pocket, and I just reimburse the promoter from the share fund, because promoters don't earn very much money, and I don't want them to be paying them. But there's a story, there's a huge story just of that patient to make it to the clinic. But how am I going to tell you that story so you realize the importance of the story that you're being part of? If you're so busy and already beyond what, what I think should be healthy for you. It's a system, it's a systems thing. And we keep our hope thinking a new world is coming. We have it in us, in that moral law within that Donald Berwick calls upon.
Dr. Schlenker, Drs. Yao and Irby have also posted resources and links to places that we can get additional community resources.
Yeah, we have
to do it.
Yeah, believe me, we canvas it all. We go and knock at many, many, many doors until one opens, if they do. So most of the time, we find some door that opens. Any more advice? I need advice.
Dr. Schlenker, kind of off my topic, but one question. Do you know any of the, I guess, managed Medicare value-based care models they're investing staff or supported teams like the CHWs or promotores?
Yes, that is one of the efforts now. I think Medicare, Medicaid both are financing CHWs. However, we have 12 years of this. Just bringing in CHWs are not going to change. They might change that one story of care for us, we little people, and that patient. But what I worry is about the trends. And our promotores are getting really burnt out. I'm worried about them. We get together, and the patients that I'm assigning to them are just so full of suffering. And then I worry about the promotores themselves. So yes, I think the more promotores are coming in and do what ours are doing, the more network could happen. But I think that we need to go to the community. I think those broken cores, they need to be done down there. We cannot substitute that. You could have the best healthcare, but if you go into a broken home where people don't talk to each other, are nasty to each other, there goes whatever the doctor prescribed. That needs attention, that needs community participation, but especially it needs community healing. Is this issue that Dr. Obai is bringing, is this internalized historical harm that now is showing up more in our young. And how do we heal those? It needs to be with them. That's why I share at the end my work with theater. Because when I ponder, should we tell the patients the relationship between these two maps, redlining and amputation? What are they going to do with that piece of information? And yet we're telling the doctors, well, there must be a way. And when we tell them caringly and respectfully, and we own the story, knowing that we can do better. But I need orientation. We need advice. And that's something that we were talking about yesterday. Okay.
Thank you, Dr. Schlenker.
Thank you,
so
everybody.
much.
And if you have advice, please send it to me. Thank you all for hanging in there and don't give up on your hearts. You are amazing. And I care for you very much.
Thank you so much, Dr. Schlenker, for your presentation today, and we want to thank everybody for joining us. Hope y'all have a good day. Thank you.